Assalamu alaikum. Good morning, everyone. My name is Dr. Srizan Kharel, and I'll be presenting on topic Priapism. My moderator is Dr. GM. So, the learning objectives of my presentation is knowing the classification of Priapism, symptomatology, and management, including diagnosis and treatment. Now, Priapism comes from the name of a Greek god of fertility, Priapos, who is usually pictured with a massive erection. And this picture shown in the slide was discovered in the wall of Temple of Pompeii that was destroyed by the eruption of Mount Vesuvius in 79 AD. So, definition of Priapism: it's a full or partial sustained erection which lasts for more than 4 hours and in absence of any physical or psychological stimulation. Usually it is painful, especially in case of ischemic, which is more common. Tumescence is restricted to corpora cavernosa. The classification includes ischemic Priapism, which is veno-occlusive, where there is low to no flow. Non-ischemic Priapism, it's either arterial and there is high flow. And stuttering Priapism, that is intermittent recurrent ischemic Priapism. Reports on the epidemiology and the cause of Priapism are generally influenced by the prevalence of sickle cell disease in the population described. The lifetime probability of a man with sickle cell disease developing ischemic Priapism ranges from 29 to 42%, and the mean age at the time of hospital admission associated with sickle cell disease was 23.8 years, and in non-sickle cell disease was 40.8 years. So sickle cell diagnosis was associated with 57% of the pediatric admission and 20% of the adult admission. So with patients who have sickle cell disease, they are reported to have Priapism in early age. These are the causes of Priapism. Before knowing that, we need to know the basic mechanism why Priapism occurs. Normally, the penis is in flaccid state. This is because the most of the blood that is diverted towards the penis are actually diverted via AV shunt, which is present there to the venous outflow. And only minimum amount of blood that is required for the nutrition to the corpora is being sent. Now, in Priapism, the AV connection, the venous outflow, they are actually blocked, or there is also abnormal continuous neural stimulation which causes Priapism. Now, causes hematologic, which is the most important cause, includes sickle cell disease, which we'll be discussing in detail later, thalassemia, leukemia, and multiple myeloma. The basic mechanism in these causes are it increases WBC counts or leukemic cells, which also increases the viscosity of the blood, decreases its flow, and causes sludging in the corpora cavernosa. Then this causes Priapism. Another mechanism is that the splenomegaly, which is seen in these cases, also increases abdominal venous pressure and causes venous congestion. That is outflow. It obstructs the outflow of the corpora cavernosa. Malignancy such as genitourinary malignancy, rectal or lung also causes Priapism. The tumor cells or the metastatic cells which infiltrate the corpora cavernosa disrupts the sinusoidal architecture of the penis, and which causes high flow Priapism. And it more commonly it causes low flow Priapism by obstructing the venous outflow again. Infection and toxins such as scorpius sting, malaria, and also spider bite, etc. They act by have multiple mechanisms. Commonly, even the bite by the snake that causes pain can cause inflammation and venous congestion. Beside that, various different mechanism of different toxins can be seen. That there can be neurotoxin, causes continuous neural stimulation again. Can be by the blockage of calcium channel, sodium channel, or inhibits glutamate release, or causes continuous nitric oxide release that causes Priapism. So trauma, straddle injury, pelvic trauma, they are very commonly seen in non-ischemic type of Priapism, but also can cause ischemic Priapism by causing again venous congestion. So metabolic disorders such as amyloidosis, Fabry disease, and gout are also associated with Priapism. Amyloidosis, there is abnormal accumulation of abnormal proteins in various organs such as heart, kidneys, or blood vessels. And the blood vessel, it obstructs, causes again Priapism, though it is very uncommon. The first reported case was seen in 1980 actually. Fabry disease, it's a lysosomal storage disorder, which is X-linked inherited. There is abnormally high level of globotriacylceramide, which is a special kind of lipid, which is metabolized by enzyme alpha-galactosidase A. And this alpha-galactosidase A is not present, so this special lipid is increased, and again it is deposited in the various part of the body, and also vessels of the penis. So neurological disorders such as syphilis, spinal cord compression, multiple sclerosis, and spinal cord injury also causes priapism, again via neural pathway. And medications such as antihypertensive, antidepressant, antipsychotic, anticoagulation, and vasoactive erectile agents cause vasoactive erectile agents are those which is also being used in the treatment of erectile dysfunction. They can cause priapism. Drugs such as alcohol, cocaine, marijuana also cause priapism. The mechanism of alcohol is not clearly understood, because in high dose of alcohol they can cause erectile dysfunction as well. It's said that in minimal dose of alcohol it causes erection, but the cause of priapism is not clearly understood. In case of cocaine, they act by increasing the libido in the central nervous system, or they can also inhibit the uptake of serotonin, and this serotonin is responsible for again vasodilatation. So ischemic or veno-occlusive low flow priapism, it's the most common form and most serious form, and it's dangerous because of acute ischemia of corpus cavernosum. It is persistent. Sorry. It is a persistent erection marked by rigidity of the corpus cavernosa and little or no cavernous arterial flow. There are time-dependent changes in the corporal metabolic environment, which progresses from hypoxic condition to hypercarbia and then acidosis. And there are a series of changes which leads to fibrosis, which will be explained in the next slide. Patient typically complains of penile pain after 6 to 8 hours, and examination reveals a rigid erection. Intervention beyond 36 hours of the onset may help to relieve the erection and pain, but have no benefit in preserving the potency. Less likely. When left untreated, resolution may take days to weeks, and severe corporal fibrosis and erectile dysfunction invariably results. The pathophysiology is the erection may begin with any sexual stimulation, thought, or even physical stimulation or administration of pharmacological agents. Once erection persists beyond 4 hours, it's not relieved, and it's not relieved by orgasm or pharmacological reversal. The mechanism of ischemic priapism now begins. Outcome and the seriousness is directly related to the severity of the obstruction and the duration of blockage of the drainage of corpus cavernosum. There is decrease in the venous outflow. There is vascular stasis, and it causes hypoxia, anoxia, and then acidosis. This hypoxia and acidosis begins after 4 hours and then increase to peak level in 24 hours. Now, penile pain occurs with a significant tissue hypoxia. It leads to loss of contractility of the cavernous smooth muscle. Various histological changes such as edema of cavernous tissue, destruction of sinusoidal endothelium, exposure of the basement membrane, adherence of the thrombocytes, and then anoxia and necrosis of the cavernous smooth muscle, they all lead to irreversible fibrosis and then cause erectile dysfunction. Now, sickle cell disease, which is the most common cause of priapism among all the hematologic causes, has traditionally been ascribed to stagnation of blood within the sinusoids of the corpus cavernosum during physiological erection, secondary to the obstruction of venous flow by sickle erythrocytes. It accounts for at least 1/3 of all the cases, and mean age of onset of priapism is 15 years. 75% of the patient having first episode before the age of 20. Now, precipitating events were sexual arousal or intercourse, fever, sleep, cold weather, or even dehydration. 72% of the patients had history of stuttering priapism 3 times per month, and mean duration of each episode was 1.2 hours. So pathophysiology of sickle cell disease means normally the hemolysis of the normal hemoglobin which is present, it releases HgG into the plasma, and this free Hgg reacts with the nitric oxide to produce methemoglobin and nitrate. So this is a scavenging reaction to lower the level of NO. Now, sickle erythrocytes also release arginase 1 into blood plasma, which converts L-arginine to ornithine, which effectively removes the substrate for nitric oxide synthesis. Now, what happens is there is a state of nitric oxide resistance and insufficiency as well, and this is termed as hemolysis associated endothelial dysfunction. And hemolysis and reduced nitric oxide responsible for priapism, whereas increased blood viscosity is responsible for painful crisis seen in SCD. Also seen in the pathogenesis of pulmonary hypertension, leg ulcers, and strokes. Now, sickle cell disease priapism is associated with decrease in hemoglobin level and increased hemolytic markers such as reticulocyte count, bilirubin, LDH, and AST. Cerebral vascular accidents are more frequent, close to episode of full-blown priapism. Aspen syndrome, that is association of sickle cell disease and priapism, seen in the patient who receive exchange transfusion, and neurological events such as cerebral vascular accidents can be seen. So, iatrogenic priapism, commonly seen with intracavernous injections. So, intracavernous injections remains an important therapeutic option for men with severe erectile dysfunction. Prolonged erection most commonly reported than priapism after intracavernous injection. Most common of these drugs are papaverine, prostaglandin E1, phentolamine, and moxicillate. The mechanism of all the actions of all the drugs were discussed in previous class as well. So most of these cases priapism result from an overdose of these drugs, and incidence is much less with prostaglandin 1, that is apoprostadal, or the combination than papaverine alone. The few cases are seen with phosphodiesterase 5 inhibitors. Methylphenidate and atomoxetine, that is used in attention deficit hyperactive disorder, can also cause a prolonged erection or priapism. This act via alpha adrenergic pathway. Stuttering priapism is intermittent priapism, which describes a pattern of recurrent priapism. Traditionally, it was used to describe recurrent unwanted painful erection in men with SCD. A patient awakens with an erection that persists for up to 4 hours and becomes progressively painful secondary to ischemia. Sickle cell disease patients may experience stuttering priapism from childhood. Patient will experience repeated painful intermittent attacks up to several hours before remission. Commonly reported precipitants of full-blown SCD priapism are stuttering, nocturnal, or early morning erections. Now, sleep-related erections take place during REM sleep, and it is androgen dependent. Sickle cell disease patients often complain of sleep-related erection 3 to 4 hours and which is associated with pain. So high flow priapism or non-ischemic priapism, there is persistent erection which is caused by unregulated cavernous arterial inflow. It's much rarer than ischemic priapism and mostly associated with trauma. So any blunt or penetrating trauma resulting in laceration of the cavernous artery or one of its branches can cause non-ischemic priapism. Most common cause is straddle injury to the crura. Other includes coital trauma, kick to the penis or perineum, pelvic fracture, birth canal trauma to newborn, vascular erosion complicating metastatic infiltrating of the corpora. So although accidental blunt trauma is most common cause, but high flow priapism occurs after iatrogenic injury during ureterotomy, corporoplasty, or deep vein arterialization. Aggressive management of ischemic priapism using alpha adrenergic injection or aspiration or shunting can convert low flow priapism to high flow priapism as well. So color Doppler ultrasound shows arteriolar sinusoidal fistula at the site of intervention if the patient has a non-ischemic priapism. So pathophysiology is a laceration of any cavernous arteriole, which can produce unregulated pooling of the blood in the sinusoidal space, with consequent erection can cause high flow priapism. It typically delayed in onset compared with the episode of trauma and may develop after 24 hours of perineal or blunt penile trauma or up to weeks. Unrelated arterial inflow creates an arteriolar lacunar fistula. The fistula forms a pseudocapsule, which takes several weeks to months. Non-fistulous type of arterial priapism is the result of dysregulation of cavernous inflow, post-ischemic hyperemia. Now, secondary high flow priapism should be suspected in a patient with rapid recurrence, persistent erection with partial penile rigidity, and which is not associated with pain. So non-fistula arterial priapism is rare complication after management of ischemic priapism. This regulated arterial inflow with or without fistula can be distinguished from persistent ischemic priapism by color Doppler ultrasound. Priapism in children, it's mostly related with sickle cell disease, like we have already discussed. May be seen in leukemia patients and in trauma, 10%. In SCD, it's 65%. Incidence is 2 to 6%. Majority of the cases have been conservatively managed with spontaneous resolution. Color Doppler ultrasound can be performed for the screening. In children with history of trauma, arteriolar sinusoidal fistula must be localized. Direct manual compression softens the high flow erection and may speed spontaneous resolution. Conservative management works in the children due to less subcutaneous fat and easily compressible crural bodies. And high flow priapism may spontaneously resolve or respond to perineal compression and icing. Now, evaluation and diagnosis of priapism. Now, history is almost important in every disease. So, physician must determine whether the priapism is ischemic or non-ischemic. So, duration of erection should be known, presence of pain or not, previous episode of priapism and its treatment if the patient has received any, use of any erectogenic therapies, medications, sickle cell, presence of any hematological disorders such as SCD, other hemoglobinopathies, hypercoagulable state, leukemia, myeloma, hereditary spherocytosis, etc. Trauma to the pelvis, perineum, or the penis. Physical examination is also important again. Extent and the degree of tumescence should be known. If it's rigid or it's just there's only tumescence, if it's tender or not, evidence of trauma, examination of any metastatic lesions or tumors in abdomen, testicles, perineum, rectum, or prostate should be examined. In ischemic priapism, corporal bodies will be completely rigid. The glands and the corpus spongiosum are not. In non-ischemic, it's not rigid. It's just tumescence is present. So laboratory testing, CBC and the coagulation profile of the patient should be checked to assess an anemia or rule out any infections or hematological abnormalities. Hemoglobin electrophoresis, reticulocyte count and LDH should be checked. Corporal blood aspiration is both diagnostic as well as therapeutic. We'll be discussing this therapeutic portion in the coming slide. Visual inspection of color and consistency of initial aspirate will reveal dark deoxygenated blood with crankcase oil appearance in ischemic priapism. That's like mobile oil. Aspirate sent for blood gas testing to see pH, PO2, and PCO2. Now, normally in room air, normal arterial blood has PO2 of more than 90, PCO2 less than 40, and pH around 7.4. In case of normal mixed venous blood in room air, again, PO2 is 40, PCO2 is 50, around 50, and pH 7.35. It's slightly less than 7.4. In ischemic priapism, the cavernous blood shows PO2 less than 30, PCO2 is more than 60, and pH is severely it's acidic. It's less than 7.25. So color Doppler ultrasound. It's recommended in evaluation of priapism is an adjunct to corporal aspirate in differentiating ischemic from non-ischemic. Differential diagnosis can include resolved ischemia with edema, persistent ischemia, and conversion to high flow state. So how is color Doppler ultrasound performed? The patient is asked to hold his penis above his abdomen, about his abdomen, and then probe at 60 degrees is and then run over the ventral aspect of the penis to check for intracavernous artery. And this is how we perform. If the patient is not unable to, if he's not able to hold his penis, then we can use another hand to hold it. In ischemic priapism, there is no flow in the cavernous arteries, and in non-ischemic priapism, normal to high flow is seen in the cavernous artery. MRI has three possible roles: imaging of well-established arterial sinusoidal fistula, presence and extent of tissue thrombus and the corporal smooth muscle infarction, and corporal malignancy or metastasis. Arteriography, which is not always done because since it's invasive, so it's reserved for those cases in which therapeutic procedure is also planned, where embolization is needed to be done. So So first aid is ice pack, cold bath, cold water enemas, voiding and ejaculation and exercise. This is done in early stage. They may relieve priapism. Then oral sympathomimetic drugs such as pseudoephedrine, propanamine, and tolbutalin can effectively reverse prolonged erection less than 4 hours. Now, pseudoephedrine, phenylpropanamine is alpha agonist, but they act via by destimulating the parasympathetic innervations and then increasing sympathetic innervation. And the butalin itself a smooth muscle relaxant, so they can effectively resolve it. Oral medication, which is not oral medication is not recommended in the management of acute ischemia, which lasts for more than 4 hours. So initial treatment of ischemic priapism is decompression of corpus cavernosa by aspiration. So aspiration will immediately soften the erection and relieve pain, and it may alone relieve priapism in about 36% of the cases. So aspiration, when combined with intracorporeal saline irrigation, will be more effective, and aspiration should be repeated until fresh, bright red blood is obtained. Now, this will lead to decrease in intracavernous pressure, pain relief. It removes anoxic, acidotic, and hypercarbic blood. So this is how we form the aspiration. A single large bore 19 gauge needle should be inserted at penoscrotal junction at 3 or 9 o'clock position. We can also go about 2 to 10 o'clock position to avoid piercing of the dorsal neurovascular bundle. So we should not go beyond 2 o'clock or 10 o'clock position. So compress the penile shaft between the thumb and the first digit just below the needle. So aspirate the shaft until it is soft. Needle is left in the place and shaft is permitted to refill and repeat maneuvers. Corporal aspiration, if unsuccessful, should be followed by alpha adrenergic injection or irrigation. And there's a video of this. Audio. Audio. Audio.
Two injections of phenylephrine
Okay.
at the 2 o'clock and 10 o'clock positions.
Okay.
And we've aspirated the corpora, the blood from the corpora on both sides. And we do a little bit of irrigation with sterile saline.
Tell me about the needles that you're using.
This is a 16 gauge dialysis catheter on the right.
Okay,
This is a 14 gauge with an angiocath.
okay,
This is not normally what we use. We normally just use a simple hemodialysis catheter.
okay.
This is why.
Y'all can stick it again?
Yeah, because it's come out of its position.
So this is the amount of blood you've gotten out of there. Okay.
I rarely see the bucket from this side right here.
So you can see.
No, we don't do dorsal
Oh, you don't? Okay.
We just
It's just a
Little
local.
wheel.
Anesthesia is given at the site of aspiration.
Let me ask for how much more blue that do you have to get that? I believe if it relaxed.
It's not necessary to irrigate with normal saline every
We actually had one time had
they come down by itself.
So even larger hematoma.
Okay, the 19 gauge or the white bore needle is fast at 3 or 9 o'clock position.
Hold on.
So with aspiration, there is repeated squeezing of the penis
Yeah.
is done to remove all the
Blood out.
blood.
Check the blood pressure.
If repeated aspiration cannot relieve priapism, then it should be irrigated with normal saline or alpha-adrenergic.
Yeah, blood test is already done at the outside hospital, and this is clearly, you can also tell.
Got a history too.
yeah.
It's gonna come back or not,
Yeah,
so
stay down.
No,
bleeding on the side.
Yeah.
Every time, but we should check his blood pressure.
Much more on the side.
Oh, no, we don't use it because it took.
This
Okay.
was already explained in the slide. I just wanted to just show how it's done. So first, the phenylephrine, if it's necessary, then it should be dilated in a normal saline to a concentration of 100 to 200 microgram per ml, and it is administered intravenously at as a 1 ml injection every 3 to 5 minutes, and it should be intermittent over an hour with a maximum dose of 1 mg. Now, in this picture, we can see one vial of the phenylephrine, and its concentration is 10 mg per ml. Now, to make our required concentration, now we add first 9 ml of normal saline to it. Now the concentration becomes 10 mg in 10 ml. We take 1 ml of it, so it's now 1 mg, and then we mix it according to the dose we required. If we mix now 4 ml to that, then it becomes 200 microgram per ml, and if we add 9 ml of normal saline, it becomes 100 microgram of ml, and we give it every 3 to 5 minutes with the maximum dose of 1 mg. So we monitor the blood pressure and the pulse rate during and immediately after intracavernosous injection. Side effect could be headache, dizziness, hypertension, reflex bradycardia, tachycardia, and cardiac arrhythmia, contraindicated in uncontrolled high hypertension, and monoamine oxidase inhibitor if the patient is using it. Sorry. Treatment of sickle cell disease. Induced ischemic priapism involved analgesics, hydration, oxygen bicarbonate and exchange transfusion. Hematologist emphasis on IV hydration, sodium bicarbonate for alkalinization, and exchange transfusion as first line of treatment for sickle cell disease associated priapism. Hydroxyurea is used in the management of vaso-occlusive crisis of SCD, such as in leukemia, even in sickle cell disease. High success rate seen with penile aspiration, injection, and irrigation with intracavernous sympathomimetics for SCD priapism. Stuttering priapism. A goal of the treatment includes prevention of further future episodes, preservation of erectile function, and balancing risk versus benefit of various treatment options. Multiple treatment options have been described, like such as oral and injectable alpha-adrenergic agonist, dobutalin, anticycling agents, hydroxyurea, GnRH analogs, anti-androgen, baclofen, and recently phosphodiesterase E5 inhibitors. And limited daily administration of oral drugs should be considered, typically initiated at bedtime. Primary action of systemic hormonal therapy is suppression of androgenic effects on penile erection. Now, the goal of hormonal therapy is to reduce serum testosterone to hypogonadal level or block the testosterone's effect on the penis. Anti-androgen have benefit over gonadotropin-releasing hormone analogs, and they can be orally administered. Now, baclofen can also be used, which acts by acting on the GABA receptor activity and thus inhibit penile erection and ejaculation. 40 mg of baclofen is used every night and can be used in the management of recurrent priapism in the patient with neurological lesions. Withdrawal syndrome characterized by return of spasticity, agitation, sleeplessness, and priapism can be seen. Now, surgical management of ischemic priapism. If conservative measures are unsuccessful, we go for surgical management, and the goal is to allow the blood flow in and out of the penis freely to prevent ischemia and then fibrosis of the penis. Principles of most of the priapism surgeries involve creation of the fistula between the ingorged corpus cavernosum and the glans, or corpus spongiosum, or dorsal or saphenous veins. Patients should be counseled regarding erectile function as well, because if low flow priapism persists longer than 36 hours, they are likely to develop erectile dysfunction. Shunting. And the shunt procedures are subdivided on the basis of anatomic location of the penis, can be proximal or the distal. And distal should always be the first choice for shunting procedures. And shunting is to be considered for ischemic priapism events that last 72 hours or less, because after that it might be of no use. And the objective of shunt surgery is reoxygenation of cavernous smooth muscle to establish corporal inflow by relieving outflow obstruction. It requires a creation of the fistula between corpus cavernosa and glans penis, or cavernosa and spongiosum, or cavernosa and dorsal and saphenous vein. Percutaneous distal shunting is less invasive and can be performed in a local anesthesia in ER. So again, it can be in distal type, it can be percutaneous or even open distal. Percutaneous includes winter shunting, EBOC shunt, T-shunt. In distal open shunting, it can be Algorab and Burnett shunt, which is also known as corporal snake shunt, and this will be described. The window shunt and distal cavernoglanular shunt procedure is created by transglanular placement of a large bore needle or angiocatheter into distal glands and corpus cavernosa. So through the, we can see in the picture, we go through the glands into the corpus cavernosa, and then we make a rent in the tunica albuginea, separating the glands and the corpus cavernosa. It's removed, and then we create a fistula between the glands and the corpus cavernosa to drain the blood from corpus cavernosa through the glands.
There's no sounds probably Karachi.
सर आपकी तरफ से म्यूट हो गया है, काइंडली आवाज नहीं आ रही सर ठीक।
अब आवाज आ रही है शक्कर वालों को?
जी अभी आ रही है सर।
ठीक है, Dr. Naseem is describing the reason why we are making shunt from glands.
Sir, shunt can be placed either proximally or distally, but in distally, maybe this is the dependent or the blood much more congested.
Where are we making shunt? Between what?
And glands.
What is shunt? You are late in presentation.
Yes.
What is shunt?
Shunts means to just withdraw the blood from the collected blood in the cavernosal space.
So you don't know what is shunt. Then how can you understand this procedure? We are basically making communication between two draining systems. Okay.
Yes.
And the reason why we are making shunt between corpus spongiosum and corpus cavernosa, Noman? You are present since start of presentation.
Mostly the corpus cavernosas are engorged, so when we are making the abnormal passage between two corporas, the engorged blood can it can recirculate through the corpus spongiosum.
Priapism, what is the structure which is being involved in priapism? Priapism is disease of which structure? Dr. Farzin. This is the reason. Corpus cavernosa is involved only. Corpus spongiosum is spared. Its drainage is not hampered. Its drainage is not blocked. That's why we are creating drainage through corpus spongiosum for the time being. So how this corporal wash will improve this priapism? Anyone? What we are doing, how we are treating it with respiration.
During the priapism, the corpus cavernosum, they are engorged. So there is a persistent erection. When we make the shunt or aspirate, first of all, we aspirate the engorged blood or coagulated blood inside the corpus cavernosa to make it not engorged.
What is in your mind, what you are doing, and you have experience of it, no? So you must know what should be in our mind, what we are going to do before going for aspiration. What is purpose?
So to achieve the detumescence, so that because patient is in pain and the venous is in erect form, and when we aspirate or we wash with saline or with phenylephrine, we want to achieve the detumescence and remove all the engorged blood. And once the engorged blood is removed and the detumescence is achieved, this is our main purpose.
What is pathophysiology of priapism? Anyone? Dr. Mariam?
Basically, there is veno-occlusion, there is venous outflow obstruction. So there is only deoxygenated blood is there. And when there is only deoxygenated blood is there, there will be vascular stasis and there will be hypoxia in the surrounding tissues as well. So it will lead to the further damage to the penis and persistent priapism. So in order to relieve that vascular stasis, we will make this shunt. And we will continue the decompression until the oxygenated blood comes. That is the red and fresh blood.
Any better answer? Anyone else who has better answer? पैथोफिजियोलॉजी पता है किसी को प्रियापिज्म की? अभी हम डिस्क्राइब कर चुके हैं डॉक्टर नसीम. More than 50% of you are late in this class. And this is reason nobody knows
Sir,
what we have to do. When we started class, only 5 to 6 students were here.
Sir, as Dr. Maria mentioned that there is actually the venous outflow blockage. So the arterial blood which is coming, that is accumulating and that leading to the accumulation of deoxygenated blood, and that collected blood is actually pressurizing on the cavernosum and that leading to persistent erection.
Pressurizing.
Yes, sir. Means the collected blood which are collecting there, that's leading to hypoxia and that hypoxia leading into the persistent erection.
Basically, potentiation of erection or any pathological issue which is causing priapism is started with engorgement of venous system and penis because of initially reduced venous return. Erection is maintained with reduced venous return and continuous arterial supply.
Yes, sir.
There is no stasis in it, but venous return is reduced and arterial supply is increased. That's why there is tumescence. But this normal mechanism is hampered by inhibition of venous return to minimum, and that causes venous engorgement and venous congestion. And when this is pathological, or when this enters into vicious circle, it causes increased intracorporeal pressure, which causes further reduction in venous return, because all the easily compressible venous return channels are being compressed and venous return is pathologically reduced, and then this vicious circle increases and more pressure generated, and then there is stagnant of blood. When venous return is completely blocked, then there is a stagnance of the blood, and this stagnance is pathological because it will cause thrombus formation, clot formation. By aspiration of blood, the main aim is to reduce intracorporeal pressure so that venous return should restart, and then stagnance should be stopped. And once again, when blood is in flow, when there is no stoppage of blood, then pathology is interrupted. We have to interrupt the pathophysiology. We have to disturb pathophysiology. And pathophysiology is stasis of the blood in venous sinuses. Okay. Proceed.
Just like other shunt procedures, we then milk out the deoxygenated blood into shunt, and once the bright red blood is seen, the skin is closed. So Al-Gorab shunt, it's a distal open technique. So open corporogranular shunt is indicated if the percutaneous shunting fails to establish the blood flow. It requires an excision of a circular cone segments of the distal tunica albuginea about 0.5 by 0.5 centimeter, and the transverse incision is made on the dorsal aspect of the glans approximate to 1 centimeter, same in the picture. When detumescence occurs, again the skin is closed, and the remaining then the defect which we have created inside is left for continuous drainage. Burnett or corporal snake shunt. It's a modification of Al-Gorab shunt, and rather than excising a wedge of tunica and underlying corpus cavernosal muscle, a Hager dilator is advanced through each of the tunica window proximally to release the blood and the thrombus. The penis is made flaccid by repeated manual compression again and released. The glans skin is approximated and urethral catheter is placed. The basic mechanism of all the shunt we have explained is basically same. To create a shunt between the corpus cavernosa and the glands and through the corpus spongiosum, so that the blood is drained, and again like Sir explained, to relieve intracavernosal pressure and reignite the outflow. Now, proximal shunts and venous bypass. If the distal shunt fails, then proximal shunting is recommended to establish a communication between corpus cavernosa to corpus spongiosum at the base of the penis. It requires transscrotal or transperitoneal approach, and it carries a higher risk of urethral injury. The venous bypass can be cavernoso-saphenous shunt or cavernoso-dorsal vein shunt. Cavernoso-saphenous shunt, also called gray hack shunt, and cavernoso-dorsal vein shunt is called Barry shunt. In gray hack cavernoso-saphenous shunt, a saphenous vein is mobilized by dividing all its tributaries and ligating it, and then it's spatulated and anastomosed to the corpus cavernosa, which drains the blood in the corpus cavernosa to the saphenous vein. In Barry cavernoso-dorsal vein shunt, we ligate the dorsal deep vein of the penis distally, and then anastomose the proximal part to the corpus cavernosa, thereby draining the corpus cavernosa into the deep dorsal vein. Now, key factors for determining successful surgical reversal of ischemic priapism are evacuation of thrombus, reestablishing of the cavernous inflow, and the patency of the shunt. Assessing of the shunt patency can be done by visualization of bright red color in the corporal aspirate after the procedure, corporal blood gas, color Doppler ultrasound, measurement of the intercavernous pressure, and penile compression maneuver, squeeze and release. Complications are also seen: penile edema, hematoma, infections, conversion to high flow priapism after treatment of low flow priapism, iatrogenic laceration of the cavernous artery, urethral fistula, penile necrosis, and pulmonary embolisms. To prevent shunt obstruction and failure, we need to avoid compressive penile dressing following procedure, periodic squeeze, and release distal penis to milk the shunt, maintaining the patency. Anticoagulation, so preoperatively aspirin 325 mg coupled with subcutaneous heparin 5000 units, and then postoperatively 81 mg of aspirin is used daily for 2 weeks. So, penile prosthesis. Natural history of untreated ischemic priapism or priapism refractory to the intervention is severe fibrosis, penile length loss, and complete ED. It is used in the management of acute ischemic priapism when other procedures have failed or it has lasted for more than 72 hours. It's more likely the patient should be counseled for penile prosthesis. Main disadvantage to immediate implantation is corporal fibrosis is not yet established. The main advantage is when the corporal fibrosis has not yet established. That's why beyond 72 hours, we advise the patient for penile prosthesis, because if you wait for several weeks or months, then it's less likely than they are not going to have any sexual gratification even after penile prosthesis. The complications include infection, urethral injury, device migration, and device erosion. In non-ischemic priapism, it's not an emergency. Spontaneous resolution may occur following conservative therapy as well. The partial erection is resolved in 4 days and normal erection 2 weeks later. Cavernous aspiration has only diagnostic role in high flow of priapism. Patient demanding immediate relief, in that case, selective arterial embolization is offered. Selective pudendal artery embolization has highest success rate, 89% to 100%. In case of long-standing priapism in which pseudocapsule develop around the fistula, surgical ligation is successful, and color Doppler ultrasound guidance is recommended during exploration to locate the fistula. This is the same thing which we have discussed, or the summary in the treatment of priapism. Thank you.